There's a conversation happening inside medicine right now that most patients never get to hear. It happens in research journals, in ethics committees, in quiet exchanges between physicians after the official meetings end. And the heart of that conversation is something that might genuinely surprise you. More testing does not always lead to better health. In fact, for people over 60, more testing can sometimes lead to outcomes that are measurably worse than doing nothing at all. Today we're going to talk about 5 medical checkups that a well-informed physician, someone who has spent decades watching what happens when the testing machine goes into overdrive, would personally decline after the age of 60. Not because health doesn't matter, not because doctors can't be trusted, but because understanding the difference between testing that genuinely helps you and testing that generates fear, procedures, and sometimes real physical harm. That understanding could be one of the most valuable things you carry into the second half of your life. This isn't about avoiding the doctor. It isn't about ignoring symptoms or skipping the conversations that matter. It's about being an informed, active participant in your own care rather than a passive recipient of whatever happens to be on the standard annual checklist. And it's about recognizing that medicine, for all its extraordinary achievements, is also shaped by habits, by revenue, and by assumptions that don't always hold up when you look at the evidence honestly. So let's get into it. The first one is going to raise eyebrows, and that's intentional. Routine full body cancer screening, the kind that's being marketed directly to health-conscious older adults through commercial scanning centers and comprehensive blood panel packages, is something a thoughtful physician would think very carefully about before reconvening, especially for people over 60 with no specific symptoms or elevated risk factors. The logic behind it feels airtight on the surface. Find cancer early, treat it early, beat it. That narrative is so deeply embedded in how we talk about health that questioning it almost feels irresponsible. But the science is considerably more complicated than the narrative suggests, and the complications matter most for people in their 60s, 70s, and beyond. Here's what the research has consistently shown. Broad cancer screening tools, whole-body CT imaging, full-body MRI packages, sweeping tumor marker blood panels, have not demonstrated a meaningful reduction in mortality for the general population of older adults. What they have demonstrated is a remarkable ability to find things. Shadows on a lung, a slight irregularity near a kidney, a protein level that sits just above a reference range. And once those things are found, a process begins that is very difficult to stop. Referrals, follow-up imaging, biopsies, more waiting, more worry. And in a significant number of cases, what was found was something that would never have caused a single day of harm, something the body was already managing quietly and effectively, and that now requires emotional, financial, and medical attention it never actually needed. Oncologists use the term indolent to describe cancers that grow so slowly and are so unlikely to ever become clinically significant that many researchers have argued they shouldn't even carry the word cancer. The label alone triggers a chain of responses in the patient, in the family, in the medical system that can lead to aggressive treatment of a condition that posed no real threat. And aggressive treatment, whether surgery, radiation, or chemotherapy, carries genuine risks for a person in their late 60s or 70s that are categorically different from the risks the same treatment carries for a 35-year-old. The body's reserves are different. The recovery capacity is different. The balance between the potential benefit and the potential harm shifts substantially with age. There are absolutely cancer screenings with strong evidence behind them. Colonoscopies up to a certain age, mammography according to current clinical guidelines, low-dose lung CT for people with a significant history of heavy smoking. These have been studied rigorously and shown to reduce mortality in the right populations. The caution being raised here is specifically about the commercially marketed broad-spectrum packages sold as peace of mind. For many people, they produce the opposite. A personalized conversation with a physician about which specific screenings make sense given your individual history and risk profile is worth infinitely more than a one-size-fits-all scan. The second checkup worth reconsidering is routine cardiovascular stress testing in older adults who have no cardiac symptoms. Let's be precise about what this means, because precision matters here. If you are experiencing chest tightness, shortness of breath, unusual fatigue during exertion, or any sensation that suggests your heart may not be functioning well, testing is not optional. It's urgent. That is a completely different situation. What's being questioned here is the routine, preemptive stress test ordered in someone who feels entirely well, with no cardiac complaints, simply as part of a general wellness evaluation. One of the most respected preventive medicine bodies in the country has concluded that there is insufficient evidence that routine stress testing in symptom-free adults improves health outcomes. And the concern goes beyond mere ineffectiveness. The false positive rate associated with these tests is clinically significant. A false positive means the test suggests a problem that isn't actually there or isn't clinically meaningful. And what follows a false positive is a cascade that can be very difficult to walk back. A standard next step after an abnormal stress test is coronary angiography, an invasive procedure involving a catheter threaded through an artery with contrast dye injected to visualize the coronary vessels. Under the right circumstances, it's a valuable tool. But it carries real risks: bleeding, arterial injury, allergic reactions to contrast material, and in rare but documented cases, it can trigger the very cardiac event it was intended to rule out. Patients who were healthy and asymptomatic when they walked in have suffered serious complications from the testing cascade that followed a stress test result that turn out to be a false alarm. What genuinely reduces cardiovascular risk, with evidence that is far more robust than routine stress testing in healthy adults, is the consistent management of the basic markers: blood pressure, blood sugar, and cholesterol. These simple, inexpensive tests provide information that guides real, meaningful intervention. Add to that 30 minutes of walking most days, a diet built around whole foods, restorative sleep, and stress that is actively managed rather than simply accumulated, and you have a cardiovascular protection strategy that the research supports deeply and consistently. The third area involves bone density scanning. Not the test itself, which has genuine value, but the frequency with which it's repeated and the aggressiveness with which mild findings are treated in people over 60. Bone health is real and important. Fractures in older adults, particularly of the hip, are serious events that can profoundly alter the trajectory of a person's life. The concern being raised here is not with the tool, but with how its results are often acted upon. When a scan reveals osteopenia, a bone density reading that's lower than ideal but doesn't meet the clinical threshold for osteoporosis, the common response is to move quickly toward a class of medications called bisphosphonates. These drugs are appropriate for certain patients in certain circumstances, but they are not without meaningful side effects that deserve serious weight. With prolonged use, bisphosphonates carry a risk of osteonecrosis of the jaw, a condition in which the jawbone loses its blood supply and begins to deteriorate. They also carry a paradoxical risk of atypical femoral fractures, stress fractures of the thigh bone that occur in a small subset of long-term users. For a person with mild osteopenia and no history of fracture, the absolute benefit of years of medication is often much smaller than it appears when described in relative terms. The decision to medicate should not be reflexive. It should be deliberate, individualized, and made after honestly weighing realistic benefits against real risks. What the research strongly supports for bone health in older adults is resistance training. Specifically, progressive weight-bearing exercise that places load on the skeletal system. This has been shown repeatedly to improve bone density in ways that cardiovascular exercise alone does not. Paired with adequate calcium from dietary sources, optimized vitamin D levels, avoidance of smoking, and limited alcohol, a lifestyle approach to bone protection is backed by substantial evidence. For someone with normal results or mild findings, repeating a bone density scan every year or two is not what current guidelines recommend. Repeat scanning every 10 to 15 years may be entirely appropriate for many people. The scan has value. The question is whether the findings lead to proportionate, evidence-based responses rather than reflexive medicalization of normal aging. The fourth area requires real care in how it's framed, because it touches something that generates profound fear: preemptive cognitive decline screening and early Alzheimer's risk testing in people who have no concerning symptoms. The fear surrounding Alzheimer's disease is completely understandable. Many people watching or listening have seen a parent or partner go through it. It is one of the most frightening diagnoses in modern medicine, and the desire to know, to have some advance warning, some sense of control, is deeply human. But the honest medical reality as it stands today is this. There is no cure for Alzheimer's disease. There are medications showing modest effects in slowing progression in some patients at early stages, and the research landscape is actively evolving. But the treatment options remain limited, and knowing your genetic risk profile or your amyloid burden years before any symptoms appear does not currently translate into interventions that meaningfully change the course of the disease for most people. What it can translate into, and what a substantial body of research has documented, is a significant psychological burden. Studies tracking people who received early Alzheimer's risk information showed meaningful spikes in anxiety and depression, reductions in reported quality of life, and altered relationships and life planning, all occurring before any cognitive symptoms had actually appeared. The information didn't change the disease. It changed the experience of the years that preceded any disease, and not for the better. The person who occasionally forgets where they left their reading glasses or draws a blank on a name before it comes back to them moments later is not displaying early Alzheimer's. That is normal neurological aging. The human brain changes throughout life. Misinterpreting those ordinary changes as warning signs and pursuing genetic or imaging-based risk assessment out of free-floating anxiety can consume the very quality of life it's attempting to protect. What is proven to support brain health with strong, consistent evidence is not a test. It's a way of living. Cardiovascular health is neurological health. What protects the heart protects the brain. Physical exercise increases the production of compounds that support neuron growth and brain plasticity. Deep, restorative sleep is when the brain performs its own internal housekeeping, clearing metabolic waste, including the proteins associated with Alzheimer's pathology. Social engagement, mental challenge, and a sense of purpose all contribute to what researchers call cognitive reserve, the brain's built-in resilience against age-related change. If meaningful, persistent cognitive changes are noticed by you or someone close to you, that conversation absolutely belongs with a doctor. The distinction is between responding to genuine symptoms and pursuing preemptive mass screening in people who are functioning well. The fifth area is one of the most widely debated in men's medicine and has been for decades: routine prostate-specific antigen testing in men over 75. The fundamental tension here is biological. Prostate cancer is extraordinarily common in older men, so common that pathological studies have found prostate cancer cells present in the majority of men over 80 who are examined closely enough. But the overwhelming majority of these men never experience any clinical consequence from it. They live fully, they age normally, and they eventually die of something else entirely, unaware that prostate cancer cells were present in their body. The cancer never became the problem. The problem arises when a PSA test identifies these slow-growing, clinically quiet cancers and the diagnosis initiates treatment. The treatments for prostate cancer, surgery, radiation, hormonal therapy, carry side effects that are not minor. Urinary incontinence, sexual dysfunction, bowel complications, profound fatigue, hormonal shifts that affect mood, energy, and bone density. For a man in his early 50s with an aggressive cancer and decades ahead of him, that calculus may be entirely justified. For a man of 78 with a slow-moving, low-grade cancer that would never have shortened his life or diminished his health, those side effects represent an enormous and unnecessary price. The leading bodies in men's health and cancer prevention have reached broadly similar conclusions. Routine PSA screening in men over 70 to 75, particularly those with other health conditions or a shorter life expectancy, tends to produce more harm than benefit. This isn't abandonment. It is a rational, compassionate recognition that treatment designed for one population can damage the quality of life of another. Men with specific elevated risk, a strong family history, or those of African descent who face statistically higher rates of aggressive prostate disease, may have a different and legitimate reason to engage in that screening conversation earlier and more actively. Context is everything. What doesn't serve most men is a reflex PSA order at every annual physical past 75 simply because it's on the checklist. What does serve prostate health is the same set of lifestyle factors that serve health broadly. Maintaining a body weight that doesn't drive chronic inflammation. Eating generously from vegetables, particularly cruciferous ones like broccoli, Brussels sprouts, and cauliflower, which contain compounds that support healthy cellular function. Moving the body regularly. Limiting processed meat and excessive saturated fat. These choices don't carry the anxiety of a positive test result or the downstream cascade of biopsies and treatment decisions that can follow. Stepping back from the specifics, everything here points toward a larger principle that matters deeply for anyone navigating healthcare in the second half of life. The most useful question to bring to any proposed test or screening is not simply, could this find something? It is, what will we actually do differently because of this result? And do the realistic benefits of knowing outweigh the realistic risks of finding out? That question, asked clearly, directly, and without apology, is the foundation of medical decision-making that genuinely serves patients rather than simply generating activity. Medicine is brilliant, and medicine is also an industry. And some corners of that industry have financial incentives that don't align perfectly with individual patient well-being. Commercial full-body scanning facilities, direct-to-consumer genetic testing companies, and comprehensive wellness panel packages are businesses as well as medical services. That doesn't make every test they offer worthless. It means bringing a thoughtful, questioning mindset to what's being offered and why. There are tests worth pursuing with genuine enthusiasm after 60. Blood pressure monitoring, blood sugar and long-term glucose markers, cholesterol and lipid assessment, thyroid function, vitamin D levels, eye exams, hearing evaluation, skin assessment for those with significant lifetime sun exposure, dental health. These provide actionable information that leads to interventions with clear, meaningful, well-documented benefits. The standard worth applying to any proposed test is simply this. Does the information this provides lead to something that genuinely improves either the length or the quality of my life? If yes, pursue it thoughtfully. If the honest answer is uncertain, if the test is more likely to generate anxiety than insight, more likely to start a cascade than to close one, then that deserves a real conversation before it happens. The people who navigate aging most successfully are rarely those who receive the most tests. They're the ones who live well consistently, who move regularly, eat real food, sleep deeply, manage stress actively, maintain genuine relationships, and approach the medical system as an informed partner rather than an authority to be surrendered to without question. They ask better questions. They understand that certainty in medicine is rare, that every test has error rates, that every intervention has a risk profile, and that the older the body, the more that risk profile deserves weight. Your health after 60 is not measured by how many screenings you complete or how many items you check off an annual wellness list. It is measured in the quality, vitality, and engagement of the life you are actually living. The goal of medicine at its best is to support that life, not to medicalize it beyond recognition in pursuit of a false sense of comprehensiveness. Bring these ideas into your next conversation with your physician. Ask the questions that haven't been asked. Push back where pushing back is warranted. And trust that a doctor who welcomes that kind of engagement is practicing the kind of medicine that has genuinely earned your confidence.